current allopathic way is looking at something in 2 dimensions. This new personalized medicine is looking at someone in 3 dimensions. The search for performance can put you at risk for longevity. The bodybuilding world is a perfect example of that, right? You could call them the original biohackers.
The science changed, the technology changed, the approaches, the testing, and etc.
I think we're beyond the point where there needs to be biohackers. They've listened to some podcasts, they've read some books, and they're throwing everything at the kitchen sink. That is not the right strategy. And people need to understand that if you're getting your health advice from a marketing person, you're doing something wrong.
Don't you get frustrated? I'm Dr. Esra Çavuşoğlu, and I've been living a sober life for the past 18 years. My battle with addiction drove me to seek new methods, devices, and supplements to improve my physical and mental performance, enhance my quality of life, and ultimately live healthier for longer. From my experiences in addiction recovery, biohacking, and longevity to the latest global developments, from groundbreaking entrepreneurs to expert academics, the conversations I've had over the years are now featured weekly on Soberhead Podcast. Welcome back to Soberhead Podcast. This week, we're exploring one of the most exciting frontiers in modern healthcare, longevity medicine. My guest, Dr. Mohammed Enayat, is a physician who bridges traditional general practice with the cutting edge of personalized medicine. In this conversation, we talk about the evolution of primary care, the rising importance of muscle health for longevity, and how urban living impacts our well-being. We'll dive into the world of biohacking and new health technologies and why guidance from evidence-based medicine is essential in this fast-moving space. Dr. Enayat also shares why one size doesn't fit all in healthcare and how personalized strategies will shape the future of medicine. If you've ever wondered what the next era of healthcare looks like or how you can take charge of your own health, this episode is for you. This episode of Soberhead Podcast is brought to you with the support of Gedik Foundation for Education. For over 30 years, Gedik Foundation has been providing opportunities for youngsters, children, and women to realize their dreams through scholarships, projects, and social work. And we're proud to be on this journey together. Investing in education is investment in the future. Subscribe and support us in our quest to bring you the most current scientific data and continue your access to the world-renowned experts in their fields as guests on Soberhead, with Turkish translation and completely free of charge. Comment on the episodes, like, and share. Dr. Mohammed Enayat, welcome to Soberhead Podcast. We recently met in Cannes, but I became a huge fan of yours. I've been following your work. I've been looking into your clinic online, and hopefully when I come to London, I'll get a chance to visit. This podcast is going to be an interesting one because not many people who moved into the longevity medicine or functional medicine still practice in the regular healthcare system. So let's start with that. You're a general practitioner in training. You have multiple different degrees that I saw. I had to research it. It's a totally different system than United States. So I had to understand what is what. You moved into the longevity medicine, and yet you're still practicing in NHS, which is the National Healthcare System in the United Kingdom. Therefore, you have probably a different point of view to look to a client because some are very privileged and the other is, can be privileged, but yet they choose to continue that path. Because in Turkey, let me give a little explanation. We have the public and the private healthcare. And public healthcare is kind of like NHS, but yet probably they're more proactive because we have lots of hospitals and a lot of doctors that people have easy access. And also the private healthcare system, yet they're all kind of like, in a way, similar to NHS because it's the modern medicine, it's the allopathic medicine. It's not like this drive of making people not get sick. So you're working in this. And first, let me ask you, what made you decide to do that twist?
What made me decide to look for better ways to help my patients? And that was ultimately the driver, is how can we make my patients healthier? How do we treat our patients that come in with symptoms that can be very debilitating? Are there any other solutions out there? Are there any other ways to identify and risk stratify the journey from health to disease for your patients better? So ultimately, to slow the decline towards disease or to reverse some of those disease states. That led me on a learning journey where I looked at different healthcare systems. I studied in different healthcare systems. I studied in America, functional medicine, in Germany and Austria, a lot of nutritional medicine, let's call it diet and detoxification, inflammation, regenerative medicine. I studied in San Diego in the US as well. Medicine around medical laser application in Germany. So that was kind of the role of photobiomodulation biologically, the role of uh, electrical activity in the brain to control different mental, emotional states that have sequelae in different biological states. So it's been a continual learning journey over the last 15 years. I qualified as a GP in the UK approximately 10 years ago, and started practicing independently as a GP in the UK NHS 10 years ago, and then applying these different ways of looking at patients through deeper testing, introducing these different tools to move people's health forward. For example, starting with supplements, nutrition, and lifestyle strategies. More recently, peptides, different types of medication, different therapies that we have in the clinic, introducing those things like hyperbaric oxygen therapy, IV therapy, NAD, electromagnetic waves of energy for muscle stimulation, transcranial stimulation for brain. We recently introduced that, ozone therapy, etc. So we've over the last 7 to 10 years been expanding continually our understanding of how to treat a patient with more data and more tools, and how to build a healthcare team for the future that knows how to use these different innovations. Some of which I call them innovations, some of them have been around for a long time. For example, high dose vitamin C or ozone therapy, but some of them more recent. And then seeing the application of those to different health states, patients that are before the traditional classification of disease. So they might not have a disease, but they're definitely showing symptoms of slowing down, energy dysregulation, resilience going down, poor sleep, symptoms of mild inflammation, rashes coming up in their skin, joint aches, muscle aches, hair loss, all of these symptoms that don't get classified into boxes just yet of a diagnosis of disease. And then also applying that methodology to people that have disease, people that have Parkinson's, multiple sclerosis, inflammatory bowel disease, complicated health diseases, cardiovascular disease, and integrating that with the traditional allopathic approaches for those diagnoses. It's been a really amazing journey, and this type of medicine is an evolution of what we in primary care can deliver. I think the UK is a great place for primary care. It's one of the only places in the world that has its own training system specifically for primary care. And what is primary care? Primary care is medicine for people in the community. So it's for patients that don't require hospitalization for their treatment. So that's the vast majority of patients, right? And so we have a training system in the UK that sets us up for that. A lot of healthcare systems don't have that. You go to medical school and then straight away afterwards, you might do an internship in a hospital and then you're a family doctor. Whereas general practice is a good baseline. So I think the UK GPs already have a good understanding of how to navigate the common conditions in the community. But this longevity medicine is an evolution of that. It's really good, deeper medicine. And so we're able to apply this not just in the prevention of those conditions, but in the treatment of those conditions that we see in primary care.
Of course, general practice is like general practitioner is more like looking to all aspect of the health. In a way, it looks very similar to functional medicine, actually. Maybe not preventing it, but when the patient comes, that you kind of try to figure out where the problem is coming from, in a way. You don't just focus to the heart or to the brain. That's how much I know. No,
Yeah,
it's not.
let me explain it. So it's like having two different glasses. Like you take your glasses off. Now you have, you, with those glasses, you see with a certain lens, right? You're
Yeah.
looking at me with a certain kind of tint. It's the same thing. General practice is basically applying the same way to look at the human body, which is a collection of organs. And then it's looking at the structural state of that organ. Do you have ulcers in your stomach? Do you have blockages in your heart, blood vessels? Do you have airway constriction in your lungs? Okay, so structural limitations or issues. It's screening and looking and treating you as a collection of individual organs. Then they have ways to treat that based off guidelines, NICE guidelines and international guidelines, which include drugs, medication, and surgery or referral into specialists. And then you get referred into the traditional system, a diabetologist specialist or a stomach specialist or an endocrinologist or a respiratory specialist or cardiovascular specialist. Now you put the personalized medicine glasses on, right? And this is a different lens of looking at the human body. Personalized medicine, call it good medicine, longevity medicine, functional medicine, is a way of not just looking at the organs, but looking at the systems that connect the organs. And by finding that system dysfunction earlier, you prevent the organ structural issues from happening. Or another way to look at it is that even if you have the structural issues, if you go to the root cause of those, you'll find system and cellular dysfunction as the root cause of those organ structural issues. So it's almost like looking at the human body with these new technology glasses that gives you more data and information and makes sense of that data and information. The old way or the current way, it's not even the old way, the current allopathic way is looking at something in 2 dimensions. This new personalized medicine is looking at someone in 3 dimensions.
Actually, what I meant is not like the comparing functional medicine and general practice, more so like, general practitioner have the understanding almost of all organs. That's what I meant. Like,
Yeah, to
when
some
I
degree.
go to a
Correct. Yeah.
GP is like, I don't need to know where exactly my pain is coming. You guys are trying to figure out where the pain is coming. It's not like going
That's
to
right.
a
Yeah.
heart doctor and then you have a pancreatitis. That's what I was trying to make as a
No, you're absolutely right.
comparison. Don't you get frustrated when you work in the classical system?
Yeah.
Knowing so much and knowing so much you can offer and knowing so much that the science changed, the technology changed, the approaches, the testing and etc., then wear your other hat and then you go to the classical way of treating someone, but you know how much more you can offer to that person.
Yeah, and you get the opportunity to have those conversations with that experience of the personalized medicine with confidence, right? So I can go into those consultations with confidence, saying, look, talking about things that they have control over, that they can do, and empowering them again to say, look, yes, this is a medical option, but actually, if you do A, B, C, D, E, that's more powerful than the medical option. And you have the power of controlling your ADHD. You have the power of controlling the outcome of your cardiovascular disease progression and your cholesterol risk, for example. You have the power of controlling eczema. For years, it doesn't need to be steroid creams for life. We can talk to you and give you back that power, but these are the choices you have to make. So yes, it is frustrating because you are limited in the access of tools. You're limited by the amount of time you have. You're limited by the patient expectations who are coming into your consultation room looking for a medication because they're still in the old way of thinking. And you're also limited sometimes by the team around you who you're referring into, because you need them to also provide some specialist opinion, but think in the same sort of way. However, those limitations do not stop you from having fulfilling consultations with your patients and moving the needle forward with them. It is harder. But it's still very rewarding. I think there's a long way to go, but in transforming primary care so that all doctors can think in this way. But definitely we're seeing a lot more patients inquiring for doctors who are thinking in this way. Patients that are saying, wait a minute, is my LDL, do I need to be on a statin, doctor? And previously, in the old philosophy, the doctors would be like, no, I know what's best. You need to be on a statin. But as the patients grow in confidence in the community to have with understanding, they're coming to doctors saying, wait a minute, but this research shows that not all LDL is bad. Can I test my ApoB? Can I test my LPA?
Hmm.
And it's putting doctors on the spot where they feel like, okay, my blind spot has been exposed. I need to go on a learning journey. And so I'm seeing that happening around in my colleagues, and more referrals coming back to me to say, actually, you're someone that has experience, not just knowledge, experience in modifying these risk factors and understanding them. Can you help us with this? So I think it's an exciting time.
Yeah, I know. I was just thinking while you were talking, probably one, your patients are very lucky without knowing that you also have the other knowledge coming to you without too much expectation and suddenly being able to be introduced to this totally different and new world. And number two, the other doctors are very unlucky if your patient suddenly decide to change town, change city, and they have a new GP. And then they're like, okay, but I thought that you had to look for this, then, and the other. And the doctor is like, no, that's the standard way of treating someone. So, it goes both ways. You're in London and I'm in Istanbul and New York and, Paris. Like these are very busy cities, capital of the world, let's say, and very eclectic, very cosmopolitan. And with all these, a lot of sets of problems comes. What are the biggest problem you see in this new fast world coming into your clinic, whether in the private or the state level?
Yeah, interesting. In the state level, I'm seeing a lot of young people self-presenting, requesting diagnosis of ADHD. They
Hmm.
almost say, I'm convinced I have ADHD. Young people. Sometimes clinics, 20 to 30 to 40% of my clinic is young people under the age of 30, as young as their teens, thinking that getting a diagnosis of ADHD and some medication is going to transform their life, is going to explain why they're not doing so well at school, is going to explain, etc., etc. So I'm seeing an epidemic of ADHD. I'm seeing that less in the personalized medicine world, interestingly. So that's one. In the personalized medicine world, where I have access to the deeper diagnostic testing, I'm seeing a lot of people with adrenal dysregulation, so on the floor adrenal glands. This leading to thyroid dysregulation. So the adrenal thyroid axis is off, and then leading to sex hormone dysregulation as well. So causing imbalance in their sex hormones. I'm seeing a lot of in the personalized medicine longevity practice. I'm seeing a lot of people with LPA driven LDL. They may be on statins, but they're not working because they're not addressing the root cause, which is the LPA. We're seeing a lot of high homocysteine. It's estimated that it's up to 25 to 40% of the population has high homocysteine because they have poor methylation. With the testing that we're doing in our baseline test, we test everyone for homocysteine and amongst other markers, we're seeing high homocysteine in approximately 40%. Now, we know homocysteine is a reflection of underlying methylation issues, which has a whole sequelae of effects and an opportunity to improve with simple intervention. That's quite common in our baseline testing as well. Leaky gut is something we're seeing commonly. We test that from the outset. So I'm seeing, I'd say about 30 to 40% of our patients have signs of occludin or zonulin in their blood. So these are proteins that break down from the small intestinal wall with lipopolysaccharides in their blood, which are endotoxins released by gram-negative bacteria. We're seeing also a silent H. pylori. That's a part of our
What is
screening.
that?
H. pylori is a bug that can cause gastric cancer. So Helicobacter pylori. It gets tested for people that have a lot of reflux, but
Mm.
before the reflux, it's called silent H. pylori. So we test everyone for that, and we are seeing, I'd say, about 15% of our patients that we test, 10 to 15%, are coming back positive with H. pylori, and they're asymptomatic, so it's easily treatable if we identify that they have it. Other things that we're seeing, just thinking through the blood tests that we look at, metabolic dysregulation. Yeah, I mean, that's common. Insulin resistance. So we're seeing people with high circulating insulins. And these are what we call the skinny fat patients. People that
Mm.
look objectively well in terms of body composition, grossly from the outside, but they have high insulin resistance caused by stress, which is driving an inflammatory response within the body. So I'm seeing that in about 20 to 30% of my patients that we're testing in our patients. We've tested through this deeper testing approach. Every patient of ours goes through 120 biomarkers from the beginning, minimum twice a year. And that gives us this understanding.
Are there any similar root causes of these problems that you were stating?
Yeah, so absolutely. A lot of it comes from our environment, right? So if we think about the root causes of it's what you consume through your eyes, ears, mouth, and nose, right? So those have biological sequelae. So we're overstimulated in the urban environment. It's causing the adrenal dysregulation. It's causing the insulin resistance to some degree. Orally, we're consuming too many chemicals, disrupting our microbiome, and also causing leaky gut, right, which drives upregulates an inflammatory response. So that's very common, just in that urban environment. And we're also not regenerating very well in the urban environment. We're not providing the environment to heal, to sleep well, and to regenerate well. And what we're breathing, especially in the toxins that we breathe when you take the underground daily, for example, the tube, or in these urban cities, high pollutants, those are also dysregulating our liver enzymes. So we're seeing a lot of signs of toxicity in the liver. Our ability to detox is impaired, and so that has fatty liver, that has other sequelae if we're not detoxing very well, including water weight, bloating. These are just some of the innocuous symptoms associated with poor detox. So these are just some of the things that we're seeing.
I know that you're very also supportive of the muscle strength.
Absolutely, yeah.
Why is that? Because, like I heard from many other people, let's say, because I spoke with orthopedic surgeons, or when we speak about the, osteoporosis or any other type of diabetes and etc. But you have on top of them, you have also an extra type of analyzing the muscles, explaining people why it's important, which muscles are important, and what are they connected to.
Right. So I think there's two main things to understand. So we're going to talk about muscles and the body from a form and function perspective. Now we know we need, from a function perspective, we need good muscle contractility. We need to be able to move our body, right? That's function, and do things with it. Now, as we get older, we know our ability to lay down muscle decreases. So that's sarcopenia, for a whole number of factors: decreasing growth hormone levels, poorer blood supply, decreasing assimilation of protein, coming from and absorption coming from. So our requirements increase to be able to even just maintain the same level of muscles. We have to work harder, so we have to understand that. Now, as those muscles shrink, what happens? The skeletal system underneath the muscles, so this is your bones and your joints, take more load. Okay, if they're taking more load through the joints, you're going to get more arthritis. And as soon as you get more arthritis or disc bulging coming from the spine, you're now leading to a big cycle of deterioration, because that's going to limit your ability to squat, to bend down, to even exercise. And so to prevent that, you need to be maintaining muscle mass around those core muscles that protect the spine, that protect the hip, that protect the knees, right? And the shoulders. So those are the core muscles that are really, really important to be working through and loading. Now, you've got to load the bones as well to get the osteoblast, or the bone cells activity, the cell turnover, to stimulate new bone cells to continually produce. That gives you bone density and bone strength, because you want to prevent a bone thinning osteoporosis that happens. And that's through axially loading those long bones through pressure. So that's going to be through jump squats and things like that, plyometric exercises as well. So those are the two things from a functional perspective. And then the other thing from a form perspective is that muscle requires calories. So muscles require energy, right? So to use your muscles, you require energy. that requires efficient metabolism. Okay, so if you're not using your muscles, suddenly you're decreasing your metabolism. Okay, so there's a massive metabolic effect from using your muscles, and metabolism is one of the drivers for longevity. We know that because if you have poor metabolism, you're going to increase your subcutaneous fat, which is very pro-inflammatory and drives disease. Your insulin is going to go higher, your glucose is going to go higher, which are all very inflammatory. So maintaining low insulin and having good efficient metabolism, i.e. your ability to take your ingredients and make energy very quickly from different sources, from your fat, from your carb source, from your glycogen source, is very, very important. But to do that, you've got to put your body through a state. So you've got to exercise. And so metabolism, and then the other side of form is the delivery of that. Metabolism is a cellular level, but the delivery of those nutrients around the body, and that's your pump and your blood vessels, your plumbing. So to have efficient pump and plumbing, you need to be putting it under stress, and you need to be kind of raising your heart rate through exercise so that you don't lose it. So there's a big strap line that I use with my patients and reinforce it all the time. If you don't use it, you lose it. Okay? So, and that happens rapidly after 40. If you don't use your cardiovascular system, you lose the flexibility of your cardiovascular system. If you don't use your musculoskeletal system, you lose it. And so it's very important that exercise is extremely important to keep the engine inside healthy in multiple ways, both cardiovascular and metabolism.
While you were talking, I started thinking of these new age humans, like biohackers. I'm sure you're receiving a lot of them to your clinic. And I'm also sure that they're having already tons of gadgets at home. They're doing it themselves. They're taking lots of supplements, and even they can go to the extremity of using peptides by themselves. I'm really curious, what do you think of them? Because I'm sure it's not making them healthy.
I think we're beyond the point where there needs to be biohackers. I think biohackers was at a point where there wasn't enough understanding amongst doctors to help them navigate. Now there's a whole sea of doctors that can help them navigate this and personalize it according to their underlying physiology and biology, right? So everything should be based off your bloods and your biomarkers and your current health state. Now, the problem I have with self management, if you're not coming from a medical perspective, is that if you've never seen disease, you might be putting yourself at risk through these interventions. Examples: I've had patients coming in from taking Fedosia after listening to Andrew Huberman's podcast with liver failure. Right? I've had, because they're not testing, I've had people coming in who are on TRT for a long period of time, and now coming off it is problematic. In their 30s, coming off it is problematic because they've got this dependence, and we have to wean them off, and it causes other issues. But not everyone's comes back to normal. So I think the search for performance can put you at risk for longevity, and we're seeing that with the bodybuilding world is a perfect example of that, right? You know, you could call them the original biohackers in some ways, right? So there is a balancing act that needs to take place between performance and longevity. If you push too much on the performance, you're putting your longevity at risk, okay, for the long term. And I think biohackers may not understand that because they've not seen the diseases of older age. They've not managed those diseases of older age, kidney disease. I'm seeing a lot of patients with earlier signs of kidney disease because they're taking way too many medicines, supplements, things like research peptides that they're buying over the counter. They don't know what's inside them. Guess what? If they're not being made to a high quality, then they're going to contain excipients which are toxic to your body, which have to be filtered by your liver and kidney, which puts unnecessary load on your kidneys, which then causes breakdown of your kidney and means that you're increased risk over time of kidney disease, as an example. So this is where I think I'm seeing people coming into the clinic with health problems that they did not foresee because they've not seen diseases before of the major organs, but they were looking for performance. They've listened to some podcasts and they've read some books and they're throwing everything at the kitchen sink. That is not the right strategy. It needs to be layer by layer. You do the foundations of health first. The key important systems need to be focused on first. Efficient digestive tract, good healthy metabolism, keeping inflammation at bay, good hormonal balance, good micronutrients. That's your key foundations. Then you can go up. Then you start talking about, once there's balance there, then you can say NAD plus. Then you can think about mitochondrial support, putting in an annual detox plan. My point is, everything at once is a recipe for failure. And an example of that is Brian Johnson's blueprint. You're looking at someone that started his blueprint with a doctor that's hardly treated patients for disease in his whole life. That blueprint plan was based off science, not based off medicine.
That doctor who lives in England, yeah? UK.
Yeah, correct. Yeah. So, science is one thing, medicine is other. Medicine is the application of science that you see in patients in real life, what happens over a period of time. And I think, we have to be careful of who we're going to for advice. And you look at that blueprint, it's not livable, right? No one can do that unless you dedicate your whole life to it. And then you put yourself at risk of over revving it too much here. And, you're putting yourself at unnecessary risk. So I think that there is some challenges, definitely. And we need to think about, do we want longevity or am I looking for performance? And if I'm going for performance as a biohacker, am I okay with the detriment that it will have in the long term? Because I don't think you can have performance. You will have downstream effects of over revving the body too much. So it's that balancing act.
There are also, I think, other categories that they may not be biohackers, but they're excited to purchase stuff to their home, like red lights and saunas and this and that and the other, and have the illusion of, they're very healthy because they're doing all these things without having a doctor like you or some other doctor like in the Longevity Docs Summit that we met. So they think that because they look lean and they don't have visible problems, they think that these products are going to be saving their lives for the long run.
Yeah, that is problematic, isn't it? I mean, look, it's got to be personalized. It's got to be based on data. How many patients have read about a keto diet and then go on to get heart disease? You won't hear about that in the podcast, but we see that in the clinic. Patients that have been following these nutritional strategies that aren't right for them because they weren't tested and they're making the decisions themselves. Now, red meat is not good for everyone. If you've got a ApoE gene, it's not good for you. You're gonna have raised cholesterol, bad cholesterol, and especially it's not good for you if you've got methylation defects because you have high homocysteine. Those two are a fire for vessel disease. They're going to get heart attacks and strokes, increased risk. The biohacking community is not talking about that because they just follow the science and they assume that one size fits all. It does not. And, as a doctor, that's my responsibility here to tell you that what I see in clinical practice, one size does not fit all. An infrared sauna, yes. Now, some of these things are genuinely good to have, but are they going to move your needle for longevity significantly? This is where the messaging from the marketing world of wellness needs to be tempered. And people need to understand that if you're getting your health advice from a marketing person, you're doing something wrong. Go to a doctor, get your blood tests done, have a personalized strategy, address those problems that you're seeing in the bloods. Then on top of that, you can do the wellness stuff. You can do the sauna, you can do a bit of the red light. That's great. But the foundations need to be checked first. You need to check the key important systems because you might be missing something really important that's going to cause massive disease. Do a cancer screen. People should be doing cancer screens every 3 years, because the amount of oxidative stress that we're exposed to is driving cancerous changes at cellular level. Cancer is on the rise. Are we doing enough cancer screening? There are tests available now that you can be looking for over 70 types of cancer in a blood test. And that will look for circulating tumor cells, the earliest detectors of cancerous changes at a cellular level that you can do every few years, especially after 45. I think it's quite important. So these are the things that truly will give you longevity, i.e. if you're regularly checking, you're going to be picking up on any changes a lot sooner, and the interventions to address those changes are easier and less problematic. And longevity is about, for me, it's about, as a doctor, preventing those diseases or identifying those diseases a lot sooner and using simpler things to take you out of those diseases, keeping you healthier for longer. Now, if you're not checking those things and you're doing infrared sauna and red light, those diseases are still going to progress. Sorry to break it to you, you're still going to get that cancer if there were circulating tumor cells there. You're still going to get that blood vessel disease and have those heart attacks and strokes if you're not checking for those markers, right? So not that these technologies are making them grow faster. No, it's just because they're not, you're not working in a targeted, smart way. Please don't fool yourselves. You're going to be healthy by having these technologies just in your physical space and you're using them. Yeah, wellness is different to health, is my point.
That was a great explanation because, we do these podcasts and, I have different approaches from different scientists, and they are all looking for a specific marker to move that needle. Let's say I had Walter Longo, and his approach is different than a ketogenic diet, and the other approach is different than a vegetarian diet. But, then I receive all these messages like, well, we don't know what to follow. I said, I'm throwing all of these out for you to have an idea. There are all these options and opportunities out there. But yes, you have to have a doctor. And I keep often saying that I may seem from outside that I am experimenting things, but no, I have amazing doctors that I'm under their care, like Dr. Elizabeth Yurth, that, she's deciding what am I going to take, what not to take, which peptide to take. From outside, someone looking at me may say that, oh, she's doing everything. She's taking all these supplements and whatnot. But they're all based on, like exactly you said, on some detailed testings, actually, not like a typical classical testing. Like the amount of testing we do, it's out of this world. Your clinic is in London and you have so many interventions. And I'm sure there's so many things out there that you chose not to. What is one biggest hype that you thought that might be great to use, but turned out like, it's not doing anything?
Yeah, good question, actually. Very good question. And this is in the translation of science into medicine, right? And I think photobiomodulation for me, I trained in photobiomodulation, and then we started doing it intravenously, systemically, different types of wavelengths of light. We didn't see as much of a positive effect as we expected to see, okay, in those. However, having said that, we have not used photobiomodulation for cancer yet, okay? So for cancer, it can be used to activate certain nutrients. You can use curcumin, for example, and then ingest the curcumin at high doses, use the laser light, and once that curcumin is in your bloodstream to activate these to make it more powerful. Now, that's what the science says, and some clinics in Germany, Austria really report some fantastic outcomes with it, so we haven't used it for that. So I don't want to paint it all with a negative brush, but in the applications that we've used it for looking for increased energy in patients that have chronic fatigue or long COVID, in the clinic, we didn't, and that's why we took it out of our protocols, and the machine is sitting there, but we don't use it as much at all. That's an example there. I mean, in terms of other types of therapies, the other types of therapies that we now go through and have been going through quite a rigorous approach of reviewing the evidence base and understanding its application in disease before we apply it into longevity. So hyperbaric medicine is a perfect example. Lots of evidence about that. And we then understand how to map that against the pre-disease state in prevention of age-related diseases. Things like ozone therapy. Now, ozone's an interesting one. When it's applied to the right person at the right time, it's really powerful. But I see it applied very loosely and not getting the most power that it can have. Now, at the right concentrations, at the right time in patient's journey, you can really move the needle in decreasing inflammatory risk, in correcting any low-grade pathogens within the body, because we know that Lyme's, Candida yeast, and some kind of bacteria is quite common for people to have dysregulation pathogens within the low-grade body, which is activating the immune system. So decreasing inflammatory risk, decreasing oxidative stress, but then also improving mitochondrial biogenesis, the creation of new mitochondria. Now, doing high-dose medical ozone requires the body to be prepared. You cannot just throw someone into ozone therapy at any given time and do it sporadically. And so we've learned that over time to do it over a 2-week protocol with sick and prescribe it to our patients depending on what we're looking to achieve in their current health state. And when you do it in those smart ways, based off experience, you can really start to see their markers improve. I think many of these technologies have a role, but it's in who do you apply it to, when do you apply it, how do you apply it, and those are the details that are emerging in practices like ours that are being applying these modalities in practice with patients.
Are there any interventions that you say, this one almost helps everyone?
Hyperbaric oxygen therapy?
Really?
Yeah. Think about it. So why is the question? Why does it help everyone? Because it counteracts some of the mechanisms of aging that happen naturally that are very hard to counteract. The decreasing amount of stem cell production from our bone marrow. We know that as we age, we produce less and less stem cells. So what happens in hyperbaric? Through the pressure effect, you get a surge in stem cell release from your bone marrow every time you go in. A release of growth factors, especially vascular growth factors like VEGF, vascular endothelial growth factor. What happens to our plumbing as we age, our blood circulation? It shrinks, right? We know in the major vessels we get blockages. So does that happen in the capillaries? Of course, right? So they shrink so that we stop delivering nutrients to organs therefore shrink. Okay? So hyperbaric is really good at maintaining blood supply, creating angiogenesis, new blood supplies. And in the disease phase, we know it works in burns, in wounds, in rectal ulcers, etc. So if that's happening in the disease state, it's also happening in the pre-disease state. So for me, hyperbaric medicine is a therapy that you can literally apply to everyone. There are some contraindications, few, but there are some. And you would dose adjust according to the requirements. So dose adjust the number of treatments, the pressure that you're doing it, the duration that you're doing it. I like that. The second one, I think, is supporting the mitochondria. There's mixed reviews around NAD+, but from our clinical application of NAD+, which has been over several years now, we're seeing that after 40, for the vast majority of patients, over 80% of patients that we apply NAD+ to, they get a noticeable improvement in how they feel and the experience of health. And that's what the mitochondria are all about, right? It's energy production. It's about taking oxygen and making energy cellular level better. But also it's a precursor to dopamine, so people's motivation improves. We apply that to the people in disease state to really understand. So I tested that initially with patients that had long COVID with energy dysregulation, and then chronic fatigue. Combination of NAD plus hyperbaric is a really powerful 1 and 2 that I think a lot of patients has a wide effect. And they're both endogenous to us. They're naturally occurring. And you can't really have toxicity from naturally occurring effects. Yes, if you lived in a hyperbaric chamber, that's problematic 24 hours a day. But, from those adaptive changes. And the newest tool that I'm seeing that I'm really loving, actually, is the tool that is reversing the decrease in VO2 max, right? So we know as we get older, our VO2 max decreases, which is basically our ability of the whole system, the lungs, the plumbing, to deliver oxygen to the cell while we're exercising efficiently so that we can continue exercising, right? And continue functioning. Because the limitation of our ability to exercise is usually our ability to deliver oxygen. Because without oxygen, then we get lactic acid, we get pain, and we stop. We're breathless, and we stop. And that naturally happens as we get older. And that's so if we can, especially for our older patients above 50, 60, improve the VO2 max, by stressing the system in a controlled manner, and that's what intermittent hyperoxic therapy does. We're seeing that people have a noticeable effect very shortly after a couple of weeks of treatment.
Can you describe that a little bit? Because my audience may not know what exactly it does.
Yeah, so that's basically where you sit on a device that has an oxygen mask. It has live biofeedback, so it's measuring your heart rate and your oxygenation at the level. And in a controlled mechanism, it controls how much oxygen you can breathe in. Okay?
Mm-hmm.
It takes your oxygen levels within your blood down to as low as 80%, and it sees how your cardiovascular system responds to it. Can you withstand it? And if it can't, it cuts out. So it stresses your energy producing systems, your heart, your lungs, and your plumbing by reducing the amount of flow of oxygen and concentration of oxygen in cycles. And then it takes you from low oxygen to a very high oxygen, so hyperoxic. And it's shown in the studies, the clinical studies, that these protocols, when you do them, this 10 to 15 session protocols, have an effect on your systems that causes a decrease in blood pressure, that improves your LDL cholesterol because you start to draw on fat as an energy source better because you're running out of oxygen, so you're looking for other substrates for energy. That increases cognitive function as well for some reason that was unexpected. That increases respiratory function, your ability to expand your lungs, increases stroke volume, the amount of blood you eject from the pump of your heart, and in total increases your VO2 max. And so you can get a reversal of decade of decline within a 2 to 4 week period. And here at Human, what we do is we combine the reoxy therapy or the intermittent hypoxic therapy and immediately do a hyperbaric oxygen thereafter to expand the effect. And we're seeing significantly improved self-reported outcomes. So within a few weeks, people are reporting, I can climb more stairs. I get tired less easily. I notice that, and they're measuring their blood pressure. Their blood pressure comes down. The requirement of medication decreases. I think this is really exciting, and we're really excited by the interplay of thinking about metabolism, how you draw on energy. The mitochondria produce energy, so metabolism and draw on different energy reserves, so fat, etc. Your mitochondria, cardiovascular and respiratory systems, the interplay of those through the combination of NAD, reoxy, which are all very, very safe treatments. And you think about the range of conditions that can improve cardiovascular disease, early cognitive decline, diabetes or pre-diabetes, particularly obesity. It's a whole range of conditions that you can start to improve. And if you can help people have the engine to do more exercise, they can do more exercise. A lot of people's challenge of doing exercise is they don't have the engine, and they tire very quickly, they get pain, and so and they're very fatigued.
I have a question. I'm pretty disciplined on following what's recommended me to do, but I see many people around me that at some point they get overwhelmed and they just I can't take this many supplements, I can't follow these regimens. They have a tendency to drop it rather than continue. So I'm sure you're facing the same challenges in your clinic. What is your approach to ease them in or keep them in the system?
There's no one size fits all. Less than, if we try to put them into buckets, I'd say less than 20% of patients follow a prescription, whether that's from us or traditional medicine. There's studies to show that, in allopathic medicine, more than 90% of prescriptions are not completed. So all from 100% prescriptions given to patients, less than 10% are actually fully followed. We all know people that sometimes take their blood pressure medications, on sometimes they reduce it, sometimes take a statin, on some days, that's normal human behavior. Very few people follow a prescription, and that to full plan. So it's about really appreciating that, understanding that, and meeting someone at their level and taking them on a journey. And that's why what we like to do is show people that they can improve very quickly. When you give someone the experience of feeling better, suddenly the energy improves. They want more of it. It becomes a healthy drug to them, wanting to feel more alive, experience life better, be more present, and then they're more likely to follow a plan. So the plan actually gets stronger over time, not the other way around. But everyone is slightly different. Some people require a stronger plan. at the beginning, and you need to reinforce that because they're so complex and debilitated. And so everyone is slightly different. We do try to use coaching methodology to meet someone at their level, and to make sure that we're not just prescribing them a plan, but we're working with them in something that's achievable and livable. And that's why we have in our care team, every patient gets a doctor and a nutritionist that works with them over 12 months. And the nutritionist is constantly there. We're there to support via email. It's about a 12-month program, a journey over time, rather than a snapshot plan that here you go, this is your blueprint and you have to do this. So yeah.
Where do you see this is going to be heading in 10 years? This technology, the approaches.
I think we will clearly understand better within the next couple of years how we apply these personalized medicine to various diseases. Okay, with algorithms of care, that's going to be established. In 10 years' time, I believe that primary care will be transformed, where this is the norm. This will be the norm, and patients will be prescribed supplements, will be supported with nutrition strategies, will have access to treatments like we have in the clinic in their primary care setting, or there'll be the new sort of hospital, which is for the healthy, let's just say, before disease, which contains these clinics that contains these suites of therapies that patients are going to be prescribed to do. I think the understanding around that will be vastly improved. I think AI is going to accelerate that, no doubt, to help in clinician decision tools, but also to help in aggregating data from wearables and helping people make the right smart lifestyle choices on a day-to-day basis. So I'm excited for the next 10 years to be 10 years ahead from a healthcare perspective. So we will see. I mean, there are obviously massive challenges as well to make sure that happens. I think it's responsibility of clinics like ours to produce data, to produce evidence. And so we ourselves are taking on that challenge ourselves internally. We've appointing a head of research. We've appointed a professor and our board to help us produce evidence from the patients and to engage with the research community. So good, bad or ugly, we're sharing what we're seeing on a day-to-day basis in applying these approaches so that ultimately, we can see an improvement and other people can learn from it. I think that's a responsibility of clinics like ours. If we do that, then we move away from this luxury setting of longevity to this is being medicine for all because other people can adopt these protocols based off the evidence. They can follow those trials in the same protocols. I think that's the future.
Is it required in the UK that a doctor like you continue their work in the NHS?
It's not required, no.
It is not?
Yeah.
Okay. But it's more trustable. I'm listening to you and I compare you with some clinics that I know, the doctor, the owner from the United States, and I feel like they may be moving a little too fast, sometimes a little reckless because, they don't have anyone controlling them in a way. For you, it's like you're still in a system, in a national healthcare system, that there's an awareness and a consciousness that, it's just kind of probably creates for the person their own self some sort of a self-control in a way.
Yeah, I think so. I think, what we're trying to do is build the governance around us so that we have the governance internally, but also externally coming from the healthcare authorities. We're just taking on that challenge. It requires investment from clinics to be able to do that because you need to invest in processes, procedures, people, and administration. But we're taking on that challenge because I see that the work that I do on the ground in primary care, NHS, I can do so much better if I had these tools that I'm doing here. And me as a GP, UK trained, means that any GP that's can do this. I'm not any more different. I just have learned these tools and have the experience of providing the experience of applying these tools and understanding. I think that's an opportunity and a challenge and an opportunity. And I'm keen to try my best with my team, grow the team to invest into this, to produce research, produce governance, so that we can be looked at from the outside, from the NHS, from other providers, and said, okay, they're delivering this responsibly, cost effectively, and this is something that's reproducible, and therefore is something that we can start to consider to educate and commission to educate doctors, to look at those test suppliers, to look at those, et cetera, so that they can start adopting it. I think that's what this is how it's going to get into the 10-year plan. This is how it will eventually get into healthcare. Otherwise, it will just remain in luxury world,
Yeah.
concierge medicine. So you need, and this is the challenge, right? Doctors need to make that decision. Do I want to build data and evidence, or do I want to see less people and therefore, be limited to the number of patients I can see? To see more patients, you need to be building a whole team, a business, reproducible programs of care. So hopefully I'll see these clinicians joining forces into clinics that are committed to producing evidence. And I think that's going to happen as well.
So you have one clinic in London, and I think you have a satellite clinic in Saudi Arabia.
That's right. Yeah.
If
So
I'm
we do
not
satellite
mistaken.
clinics in Saudi Arabia. We have our flagship is in London at the moment. We see people from around the world via telemedicine, but they need to stop into London. Usually, it's the easiest way to get their bloods done once, and then thereafter we see people from around the world. Our longevity medicine it's just gone up to £349 a month on a 12-month program of care. And that includes the doctors, nutritionists, the team that supports you, and twice annual blood tests. And I think that is the future, making it cost effective, making it reasonably priced, but getting access to experts, that level of expertise. And in our clinical team, we have at the moment eight functional medicine GPs, UK trained GPs, 8 to 10 functional nutritionists, anaesthetists, cardiologists, rheumatologists, oncologists in our team as well. So we're looking to continually expand this so that we can bridge good medicine with allopathic good medicine, because they need to work hand in hand.
All these people, if there's a problem with, let's say,
Right.
the heart or the cancer or whatnot.
Absolutely, yeah. And then we can engage with the secondary care system or the tertiary care system if we need to, the good stuff from traditional medicine. So sometimes patients will need chemotherapy at times. Patients will need arthroscopies. They will need surgical interventions. They will need medication at times. We cannot live in a blind spot and a bubble to think that medication is the problem. There is a requirement for many patients to be on those tools, but not forever. And that's the key. So it's understanding that and working together with traditional medicine, not against traditional medicine.
Dr. E, thank you so much for your time. And that was really a nice ride because, it's just like, sometimes I'm very focused to one subject, but this was covering everything that one needs to kind of know, not to do, what not to do, what to do, and so on and so forth. And there are a fair amount of people who go back and forth to London, and it's easier than the United States for Turkish people. And they started dropping the US trips and more to the UK they do. And they're always asking me new people to meet, new doctors. And I know you have already patients from Turkey or they're living in the UK. But thank you for your time. And hopefully, I might be coming there at my birthday, October 11th. So I may get a chance to see
you
you in
must.
person.
Let's celebrate your birthday together.
Yeah, thank you.
You're very welcome. Thank you, Ezra.